The other important indication for oral steroid hormones or other formulations is, of course, menopause. There are some short-term symptoms of menopause. All of them are due to a decline in endogenous estrogen production, leading to an estrogen deficiency. The short-term symptoms affect 80% of all women. The most common of these short-term symptoms are vasomotor instability, hot flushes, night sweats, palpitations, and headaches. Occurring in the short term, there is, however, no way of predicting for an individual person how long those vasomotor instability symptoms will last. There are also associated with that estrogen deficiency some psychological disturbances, fatigue, insomnia and depression, loss of libido, poor concentration and memory, lethargy and irritability. We'll look also at the longer-term effects of menopause before we look at hormone replacement therapy and the benefits and, of course, risks that it poses. Urogenital dysfunction is impaired long-term. This can affect some women as well in the short term. These symptoms are due to atrophy of tissues in the genitals. These atrophic changes lead to vaginal dryness, itching, bleeding because the tissue is very easily traumatized. It also leads to changes in the pH of vaginal secretions. Because they become more alkaline, this increases the incidence of vaginal infections. There's also more pain associated with intercourse, dyspareunia. The tissue atrophy affects other parts of the urinary system, the urethra and pelvic floor, and all of these atrophic changes lead to urinary frequency, urinary incontinence, post-voiding dribble, and non-bacterial urethritis, perhaps of viral origin or an inflammatory origin. There are long-term consequences of menopause on the blood vessels and heart. Estrogen actually has a protective effect on the heart in women. So in postmenopausal women, because of the estrogen deficiency, there is a loss of these cardiovascular protective actions. These women are at greater risk of angina and myocardial infarct, basically the heart attack. Estrogen deficiency also affects lipid metabolism. There is an increase in plasma triglycerides, an increase in low-density lipoproteins, and an increase in total cholesterol. Low-density lipoproteins are cholesterol carriers, taking cholesterol away from the liver to the tissues. However, there is also a decrease in the levels of high-density lipoproteins, which take cholesterol back to the liver for further processing and excretion. These HDLs have a cardioprotective action, and so in postmenopausal women, that loss of cardioprotective effect of estrogen could be due to this drop in HDL levels. Estrogen itself also has favourable actions on vasoreactivity and platelets. As we saw, these are beneficial, but in some women lead to adverse effects, greater risk of thromboembolic events while the person is on the pill. And even for a woman who was premenopausal and experiencing natural hormone cycles, they have it's particularly the estrogen that has the positive effects on platelet activity. So postmenopausal, there is a loss of that coronary vasoreactivity and a loss of those platelet effects, and perhaps this contributes to the higher risk of cardiovascular events. The best known long-term consequence, though, of menopause is loss of bone density, osteoporosis. It's systemic, it affects all bones. From the outside, they still look as if they are the same mass. There is no change in length. It is inside the microarchitecture of the bone that is affected and loses its density. Because of this loss of microarchitecture, there is greater fragility of those bones, and the consequence of this is a greater risk of fracture. The estrogen deficiency that occurs in postmenopausal women is the most important contributing factor towards this increased risk of osteoporosis and fractures. The loss of bone density starts before menopause, but is not significant. Postmenopausally, there is a great increase in the loss of that bone density. Bone mineral declines at a rate of at approximately 1 to 3% per year for the 10 to 15 years that follow the menopause. So hormone replacement therapy, once again in different formulations, estrogen or estrogen and progesterone combinations is the most widely used strategy to prevent those cardiovascular events and osteoporosis associated with estrogen deficiency. Hormone replacement therapy, HRT, is prescribed to manage those symptoms in the early stages, the vasomotor symptoms and the psychological disturbances such as insomnia, irritability, loss of libido. But hormone replacement therapy is also indicated to reduce those risks of estrogen deficiency. It is prophylactic in this respect. It is preventing the osteoporosis and preventing deterioration of cardiovascular physiology and preventing cardiovascular events. The long-term benefits are in question and are being studied by major clinical trials. There are several formulations. We talked about how it could be estrogen alone or estrogen in combination with a progestogen component. So some oral formulations there and some transdermal patches. As the name Estroderm suggests, it's an estrogen-only formulation. There are also estrogen implants, testosterone implants. Tibolone is an interesting steroid taken orally. It is activated to an active metabolite in the liver, and this metabolite is gonadomimetic. It has both anti-estrogen and estrogen properties. It has progesterone actions as well. Sometimes all that is needed in the early stages of menopause is to address the symptoms of vaginal dryness and itching and increased risk of trauma to those tissues. Topical estrogen or a topical progesterone and estrogen cream can be useful to address that vaginal itchiness. This can prevent a lot of the pain on intercourse and can improve the person's libido without the need to take an oral steroid hormone. The adverse effects of taking the hormone replacement therapy, HRT, breast tenderness and enlargement, fluid retention and bloating, nausea, headache and migraine are the commonest, but also cholestatic jaundice, leg cramps, oddly perhaps an increased risk of thrombosis and embolism, those thromboembolic events that we were talking about, pelvic discomfort, cramping, psychological symptoms, so long-term perhaps it doesn't address the depression and irritability and could perhaps produce anxiety. Unlike the promises, maybe it decreases libido in some women and it can cause menstrual bleeding in some women. So it's important to weigh up the benefits that are actually seen against possible risks. The risk-benefit analysis is highly controversial. and so for women it is a very emotive issue. Many clinical trials have been conducted to actually show those long-term cardiovascular benefits and decreased osteoporosis and decreased incidence of osteoporotic fractures. So these would be the benefits, but also these long-term studies will show any associated safety concerns such as increased risk of cancer. Two particular trials recently publishing findings, the Women's Health Initiative, WHI. This is a very large sample group because these are healthy women, 16,608 women in their sample group. All of them postmenopausal, and they were able to follow up on those women for a mean of 5.2 years. In another study, heart estrogen progestin replacement study, with estrogen spelt the American way without the O, giving it the acronym HERS, H-E-R-S. This is a smaller sample size, but these women have coronary disease. So 2,736 women, all of them postmenopausal, and they were able to follow up with these women for a mean of 4.1 years. It would appear then that for 2 decades of hormone replacement therapy, looking at the risk of cardiovascular disease, hormone replacement therapy was seen to in fact not decrease the risk. In that study of WHI, it was seen that there was an increased risk of breast cancer. There was increased thromboembolic events, and this led to an increase in infarcts. So quite the opposite of providing cardiovascular disease protection, there was greater risk of heart attack. So based on the findings of the WHI, as well as the HERS study, they did what is called meta-analysis by the American Heart Association. This association now supports the finding that there is nil benefit in prevention of stroke or heart disease by taking hormone replacement therapy. But as far as osteoporosis goes, in Australia, for many reasons, our population is ageing. By 2050, 22% of the population will be over the age of 65. Vertebral wedge fractures in women over 50 occur with an incidence of 20 to 25%. These statistics worry health providers because this will be significant. There will be greater healthcare costs, but also significant morbidity for these women and the risk of greater mortality. Randomized trials using placebo controlled clinical trials show hormone replacement therapy or estrogen alone therapy increased the bone mass density by 4 to 6% in the spine. So this will lead to a much lower incidence of vertebral wedge fractures in the future. Bone mass density in the hip, an even more dramatic increase, 23%. This was maintained for 3 years of that hormone replacement therapy. Observational trials also indicate reduction in fractures for women on hormone replacement therapy or an estrogen-only replacement therapy, and an improvement to reduce hip fractures by 1/4, 25%, and a reduction in non-spine fractures of 35%. Hormone replacement therapy is most effective at producing these effects on osteoporotic fractures if it's started within 5 years of menopause and used for at least 10 years. The WHI study demonstrated a 34% risk reduction over those 5.2 years. Remember, that's an average. This included a reduction in hip, vertebral and other fractures. So despite there being quite clear benefits in terms of osteoporosis reduction, the other findings of the WHI, other findings that appear to be in consensus, show that there's only short-term symptomatic relief and to seek other alternatives for long-term prevention of osteoporosis. So hormone replacement therapy, the risks and benefits: breast cancer, estrogen alone in postmenopausal women increased it by 2%. Estrogen with progestogen increased the risk of breast cancer by 4%. There is a greater risk the longer that you are on the hormone replacement therapy. Cessation after more than 5 years on hormone replacement therapy diminishes that risk back to that for the rest of the female postmenopausal population who are not on hormone replacement therapy. The WHI trial also demonstrated an increased risk of invasive cancer compared to the placebo group. There was a 26% relative increase. There was no increased risk in the rate of in situ breast cancers. The absolute risk observed in the WHI study over those 5 or so years of the trial compared hormone replacement therapy group with the placebo group. There were 4 to 6 additional cases of invasive cancer per 10,000 women. So all in all, it would appear then that the risk of breast cancer will increase in women who use hormone replacement therapy for longer than 5 years. Other risks looked at: endometrial cancer. The lifetime probability of developing endometrial cancer, 2.6%. However, in women taking unopposed estrogen, this rose steeply to 19.6%. After stopping the estrogen, or with the addition of progesterone, restores that lifetime probability back to that for the rest of the population, 2.6% risk of endometrial cancer. Another trial, the postmenopausal estrogen progestin interventions trial, the PEPI trial, once again spelling estrogen without the O. This trial showed that 62% of women given conjugated estrogens for 3 years developed an endometrial hyperplasia. Patients taking an estrogen-progesterone combination did not show evidence of this endometrial hyperplasia. So the summary of the PEPI trial was that in women who have an intact uterus, estrogen alone therapy increases the risk of endometrial cancer. This risk was greater the longer that you are on the therapy. The risk remained for 5 years after cessation of the treatment. However, their conclusion that progesterone in combination with estrogen is recommended in all patients who take hormone replacement therapy and where those patients have an intact uterus. Other cancers. Studies looked at hormone replacement therapy and colorectal cancer. There is evidence of a reduced risk. So a nurse's health study demonstrated a protective effect, and that WHI study found a decreased risk of colorectal cancer with a finding of 37% decrease. Also looking at gallbladder disease. The oral contraceptive pill and hormone replacement therapy leads to an incidence of gallbladder disease because estrogen is seen to change the bile composition. This leads to an increased cholesterol level in the bile and increased precipitation of that cholesterol in the gallbladder as gallstones. There are certain contraindications to the use of hormone replacement therapy. First of all, the contraindications to the use of the estrogen replacement therapy. If there is any unexplained vaginal bleeding, active liver disease, chronic impaired liver function, recent vascular thrombosis with or without an embolic event, if the person had breast cancer or endometrial cancer, then hormone replacement therapy would be contraindicated, particularly the estrogen replacement therapy. Conditions that only constitute a relative contraindication, so where there would be use with caution: seizure disorders, hypertension, migraine and headaches, a familial hyperlipidemia, thrombophlebitis, endometriosis, gallbladder disease, and uterine leiomyomas.